Good afternoon, everyone. I'm Glenis Scadding, Vice President of EUFOREA, the European Forum for Research, Education and Advocacy in Respiratory Diseases, and it is my great pleasure to very warmly welcome you to this afternoon's symposium on shaping the future of respiratory care. Now today, April the 23rd, is a very important day. It is St. George's Day, the patron saint of England. It is William Shakespeare's birthday. And it is also the 10th birthday of EUFOREA. Now, and hope springs eternal. Here's spring, and EUFOREA is springing forth with new hope for better care in respiratory diseases. Being a modern girl, EUFOREA had two male parents. The European Commissioner of Health, Vytenis Andriukaitis, asked Professor Peter Hellings to found EUFOREA, and Peter has done sterling work, working extremely hard to get this organization off the ground. She also needed a fairy godmother, and that was in the form of a very generous donation from the Bailey Latour Foundation, for which we are very grateful. And the one dream of EUFOREA is this: one organization joining forces with all stakeholders in the respiratory field, working with patients, physicians, politicians, and industry for the good of mankind. And that is our very important aim. And for those of you who are watching the video, you can see that we've been doing quite well so far, but the future is even brighter. We live in very interesting times. And I'm now going to hand you over to the two chairs for this symposium. Having been the product of two men, EUFOREA is now dominated by women. And of the board, Peter and myself, and the other two are Dr. Vibeke Bakker from the Rigshospitalet in Denmark, and Professor Susan Lau, who is from the Charité in Berlin. And I would like to invite them to come and chair this symposium for you.
Yeah. We just say hello and good afternoon and welcome to this thrilling symposium. I hope you are curious to hear the elaborate speaker coming from different places, and we are very proud that they made their way here.
And the different topics they will cover is from patient to physicians to surgeons to politics. Yeah?
Yes, you start to announce the
Yeah, I will start, and we will jump in together. And I will start, and I'm very privileged to be announcing the first speaker, which is Xander Bertels. He is serving as the manager of the Patient Advocacy Board and Advisory Board. And he is also employed in EUFOREA full-time. He's also a postdoc in Ghent University Hospital in Belgium. And he will present his presentation will cover the patient and the societal needs for chronic respiratory diseases. Please welcome.
Good afternoon, everyone. Oh, my bad. Good afternoon, and thank you, Professor Bakker, for the kind introduction. I want to talk today with you about chronic respiratory diseases, or CRDs, and more specifically the patient and societal needs. And I think that's a wonderful way to introduce the other speakers as well, and the things that they will say. So I will cover 4 diseases, the 4 most common CRDs, which are in the upper airways, chronic rhinitis and chronic sinus disease. And in the lower airways, asthma and COPD. And all of you are familiar with those 4 diseases, I assume. And most of you will also know the impact of these diseases, both on a clinical level, policy level, on a patient level. But the question is, are we doing enough? That's the real question, especially today. And if you look at the numbers, you will see that we aren't doing enough. Because 1/3 of the total population suffers from one or more of these diseases. And that has a huge, massive health economic impact on our society. And if you would sum up the direct costs, the indirect costs, as well as the years lost because of disability, early mortality, you get to a total number only for Europe alone of exceeding 380 billion euros. And that's, of course, insane, let's say. And that is in sheer contrast with the amount of public funding that is currently being allocated to CRDs. Because for the EU4Health budget, only 0.1% of the budget is allocated to CRDs, which is totally unacceptable, even for the coming years, up until 2027. Now, this is totally unacceptable from several perspectives. From the patient perspective, of course, because patients suffer from these diseases. They have a huge impact on quality of life. That's obvious, of course. But from the scientific perspective as well, because there has been a huge amount of new insights, new findings each year on several congresses. They pop up, but we need implementation. We need to do something actually with a lot of these new insights, and that is critical. From a payer's perspective, of course, because we're more and more inclined to progress to a value-based healthcare system, which would be beneficial, of course. From a societal perspective, because we can't allow such huge numbers of patients, even up until today. And of course, for the medical perspective, where there are really little efforts for systematic screening and referral, for prevention, for collaboration between all stakeholders in upper and lower airway diseases, and the lack of focus on value-based healthcare. So yeah, indeed, I am the advocacy manager at EUFOREA. And at EUFOREA, we believe that you always start from the patient's insights. And from talking to them, letting them raise their voice, letting them address their unmet needs. It's also what we did in the morning. And we currently established a patient advisory board of 75 patients across the EU, several nations in the EU, the UK and Canada. And these 75 patients, these are really dedicated patients that want to shape the future of care. And they typically had a long disease journey. They had a patient journey where they have lessons learned on how to optimize for others and to improve that. And the patient advisory board of EUFOREA, well, we include all patients with chronic respiratory diseases. So it try to be holistic and not think in silos, which have historically been structured that way. It's patient organized, and we try to be global to see cross-country differences as well as within-country differences. Now, and if you look at some of these diseases, like asthma, CRSwNP, and even skin diseases like atopic dermatitis, you see that there's often a common shared pathophysiological mechanism, type 2 inflammation, and these people often suffer from more than one disease. Now, this is also true for non-type 2 inflammatory diseases. Most patients with COPD, about 30%, have also a mixed pattern with type 2 inflammation. But all the other COPD patients, they also show this kind of multimorbidity. COPD is one of the diseases with the highest number of comorbidities, with frailty, cardiovascular diseases, metabolic diseases, impact on mental health. So recently, very recently in January, we performed a survey amongst our patients, and we asked them, what are the most important shortcomings of care for you as a patient? And they identified them, going from a long time until proper diagnosis, a lack of patient education, a lack of primary care education and commitment, up until the 10th one being unnecessary exposure to systemic corticosteroids. Now, these are 10 problems that will keep popping up unless we do actually something about it. And that requires implementation. And at EUFOREA, that's a little bit our mission, to improve clinical practice and improve clinical care in daily practice. And we do that through a way that is, I think, unique, because you combine the insights of the patient, so bottom-up approach, and you combine that with the top-down approach from experts who have a wealth of knowledge, and you try to craft outputs that can improve that implementation. Now, one of the examples here is the patient portal, which was recently launched, and this showcases a lot of, well, information, credible, trustworthy information, comprehensive information, targeted to patients, and is now launched for CRS and will launch also for asthma, COPD, and respiratory allergies as well. But still, I would like to convey the message, and, well, really convey it, that we aren't doing enough. We are still not doing enough. I think we need to expand. We need people with who can strategically execute some of these things, because this is a global problem. This requires both regional efforts and international efforts, and we should act. And that's a message that I want to give with this short lecture. And one way, I think, and this is my personal opinion, is to see diseases like asthma, COPD, CRS, allergic rhinitis, to really unite them and to actually see them as a whole within the CRD approach, the chronic respiratory disease approach. And that is a message that we try to convey at EUFOREA. It also combines, of course, insights from how can we focus more on prevention, because we're in the business of healthcare, but we're not preventing people who are currently healthy from getting sick, and from patients from getting more sick. So that's really important. And I think currently the momentum is there. I think stakeholders are joining forces on this mission, and that's great. And what we really need for that to be successful is also an improvement in health policy. And I think there are a lot of new output that are really, really relevant, really pertinent, like the COPD index, the severe asthma index, a recent health policy paper on CRSwNP, as well as WHO now crafting guidelines for improving primary care in CRD field, and with EUFOREA through the Dept program. And with that, I want to end my short talk. So this was clearly not a presentation to convey research findings, but it's to set the stage and get us all into the same mission of arresting the epidemic of CRDs. Thank you very much.
Thank you for a nice presentation. And you set the scene, and now we know that we need to do something about it. And to start to do something about it, I would like to invite Professor Klaus Rabe on the stage. Klaus Rabe is director of the department in pulmonology in Germany. He is also professor at the university in Kiel, and he has many publications. He has had his hands in everything. He has been in the GINA, the GOLD, that's asthma and COPD. He has also been chief editor of the European Respiratory Journal, and you were also head of the Respiratory Society. So welcome on the stage.
Thanks, Vibeke. My hands are clean. They're not in everything. Thank you very much. Happy anniversary, happy birthday, EUFOREA. I know why I'm here. I apologize for having to rush off afterwards, but someone has to work. So basically, I thought it was very nice, your connotation, sort of, how this came about. And I knew it was Shakespeare's birthday, but I didn't know it was Church Day anyway. I've been asked to talk a little bit about transforming care, and the motto is inspiring the future, and that's what I'm trying to do. And I will try to rattle the cage a little bit. Those of you who know me expect nothing less. Because, yes, Witzke says, because there's something really happening now, and this is what will happen to asthma, COPD, and overlap syndromes. And there's a time where major changes are about to occur, and I think we are at one of those times now. And I was asked to talk a little bit under this transformation, under the angle of therapeutics, interventions, drugs. And this comes in quite handy because this is my bias and my interest. I've been involved in drug development all my life. I've been interested in clinical trials because I happen to believe that in respiratory medicine, the quantum leaps always occurred in the conjunction of drug development. In areas where we understood more and where we actually had a very different angle of what we're doing, to me inherently was related to drugs. Inhaled corticosteroids for asthma, long-acting bronchodilators, combination therapies. But then we went through a valley of death where there was very little innovation to be coming and sort of being developed. And that has sort of paved the way to something which is a little bit awkward and need to be rectified. So I'll tell you a little bit of a story about the last years, and that is, I think we understand now much more that chronic respiratory diseases have a long history once they occur in anyone that's been diagnosed. This is probably more pertinent in COPD than in asthma, because in asthma we believe it could occur at any age. But in COPD we're used to make a diagnosis at the age of 60, brown fingers, morbus Marlboro, and so we have a phenotypic recognition of diseases. And we've been dabbling with this because we had sort of common denominators. And the common denominators on the right were that we actually looked at lung function, if you want. This was the currency for many, many years. In the currency of an area which was phenotypic medicine. This was pattern recognition in a given individual that you thought had this and that pattern. Measurements, nil. Opinion, a lot. Putting them into strategy by managerial customs. What is paid? What is the disease management program? What is the context under which I'm doing this? This was the issue. And we came up with something that we said, listen, there's a common denominator somehow, but the only thing we could actually do was infer lung function, improve this, and had this emphasis on exacerbations because all the legislators wanted exacerbations. So we made them convinced that this is the most expensive thing you can have. And so basically this was governed by that area. If you now look at the reality of chronic respiratory diseases, this is 2024. This is lung function, peak flow variability. I mean, this is interesting, isn't it? Basically, it's a symptom-driven diagnosis in primary care which lacks biology from beginning to end. And it results into something which is predictable. Everybody in this world gets the same drugs from here to Tokyo. They are always the same drugs that will improve function to some extent, improve symptoms to some extent, and the Holy Grail, reduce exacerbations. This is short. This is not very good. And then we have this, the stepwise approach to therapy. Well, you have to go through this valley of death for years because before you deserve to get a proper treatment, then you made it to step 5. You have this part of where you actually have a thinking that you go from a symptomatic individual that is not controlled, this other non-word, it's not controlled. For a German that sounds really weird, to be honest. And if you are not controlled, you get to the next sort of step. That is our thinking. What is it driven by? It's by symptoms. It is by phenotypes. It is by clinical appearance. Where's the biology in this? I know that the people that write this are aware of the biology, but it's not there for primary care. It's not there for translational science in it. And then you have this disease we call COPD. This is a phenotypic characterization. Emphysema, bronchitis, multimorbidity, you have it. And then we're thinking about endotypic changes to understand where this lack of alveolization comes about and what you have certain inflammatory parts of it. But then you have this conundrum which comes from the Lancet Commission to understand, yes, it's much more heterogeneous. There is even the influence of birth, genetics, not only cigarette smoke in the developing world. So the idea is actually there. But that's a treatment algorithm. My God. So this world is separated in either having dyspnea or exacerbations. Thank you very much. And there's a line in between. So you either are dyspnoic or you have exacerbations. How do we believe that primary care physicians would actually translate this into a meaningful algorithm of treatment? And be assured they don't. Everybody gets everything of the same kind. And everybody more or less ends with the triple therapy for the rest of your life. I'm not saying that these are bad medications, but I'm telling you we are monotheistic by lack of innovative therapies, and the idea that you actually have to translate it into something meaningful, which will be phenotypic change, symptoms which are important to give an individual, but it lacks a biological smartness and alertness to understand, and the buzzword is to talk to each other, to get them people out of silos. It has to do a little bit with our understanding of the 60s of immunology in terms of what is IgE mediated, what is sort of, cutaneous reactions, how do you test it? But what has come up is that we have a complete different understanding of types of immunity that have a different categorization, and they are circling around messages that are targetable. We have druggable targets in this inflammatory cascade, which is the game changer. The game changer is that not that we are addressing inflammation to some extent, but we're addressing pathways and pathobiology that you have to understand that has a novel and new segmentation in immune responses. And believe me, this is something which is not there up front. It is what we call trained immunity in a given individual. So yes, we have this understanding that these diseases begin early, but we now understand a lot more what is actually really happening, and I'll tell you a little bit about the data which I think are inspiring for disease classification. If you take these immunobiological patterns, we have a cohort in Germany which we call Alliance. It includes individuals starting from the age of 4 weeks, and the oldest individual is 89. Alliance is because pediatricians and adult individuals sort of, collect these data. And the Alliance shows you that if you look for type 2 inflammation, and with this very attractive videoing, you can't see the colors, but I tell you what you see. It tells you that type 2 inflammation in the pattern of this occurs starting from the age of 2. So this is something which is not occurring when you're symptomatic. It is a pedigree, an immunological imprint that you are bringing upon the table, which then has the factor of time, and it secondly has an exposome which will, certain parameters will be highlighted or not. So it's a common pedigree and pattern. This is what is taking this out of the silo in this, and this is lifelong. So if we look at treatments, we are used to look at treatments of new therapies on our classical parameters of lung function and exacerbations, what have you. But the conundrum really is, what does it do on the biology? What does it do on the biomarkers that you have to actually impregnate or actually describe the immunology behind it? And you would see, it doesn't always go hand in hand. You have to understand and have to develop a completely new thinking about a successful treatment, which will have to come earlier in life. It will have to follow immunological reasoning and biology, and it will have to understand that the markers of success is not your FEV1 on your peak flow variability, for Christ's sake. It is something else, and that's something that we'll have to learn. Now here, all the allergists in the room, you have to be very brave now. Biomarkers and driving immunology is important. So if you want to predict whether someone will benefit from immunotherapy, you would think it is your skin prick test, and your IgE, and your storytelling. What it is, it's biomarkers. It doesn't matter to what you're sensitized. If you are eosinophilic, you have tryptase, you have ECP around, then you're a better candidate for immunotherapy for allergy. So it actually questions the whole thing and the whole reasoning and our measurements in that. And if you look at combining allergy tests with biomarkers in your response to immunotherapy, who wins and who loses? The losers are the zeros. And it's for everything that you look at. So biological reasoning, understanding immunology, and when it starts as a pedigree that you start with, is the key to develop new drugs, first of all. And once you've done that, you learn where you will be going with these tools. And this is how medicine is about. And basically, if you then take these drugs and you say, listen, I'm treating someone that has asthma, it doesn't matter whether he is allergic or not. It matters whether he's eosinophilic and has an INO marker. Your clinical allergy, I told you have to be brave now, the clinical diagnosis of allergy does not confer into a therapeutic benefit or a difference. So with other words, if you want to save money, I know where you can save it, to be honest. If you look now at individuals that have the disease asthma, and you see how does it drive our known factors, exacerbations. There's no question that if you look at the two right panels, that if you are biomarker low for EOS and NO, your risk of exacerbation is low. And if you're on the upper right corner, you're in the hot area of this, where biomarkers drive longitudinally your certain risk. So what I'm saying, yes, clinic does still play a role. Yes, there are clinical parameters of that, but never in isolation. They will be governed and they will be directed by biomarkers in them. And even something that we haven't understood for quite some time is that loss of lung function over time, which we always relegated much more to chronic obstructive lung disease, but it occurs in asthma as well. What drives this decline of lung function, what drives factors of remodeling, question is when should you interfere? It is to be biomarker high, both on the pheno and second on the eosinophils. Is that sufficient? No, we need to be more of these things, but that is the learning point where this medicine will be going, it will need to be going. And in COPD, we're going the same way. This is not that developed yet, but we're going the same way because we understand it's not comorbidity, if I may correct you. It's multimorbidity in given individuals that have a certain pedigree of things go wrong. That's what the Americans call badly constructed. Individuals that have different problems, given with the same insult, giving you a greater effect. And we understand also there, it's early development of a given individual, and it is immunologic pedigrees that drive you to a lack of alveoli, hence emphysema in the end, or a chronic inflammatory response driven by neutrophils, leukocytes, and neutrophil eosinophil-driven ones. It's early, it's trained immunity that will actually be then influenced by cofactors that is the same for COPD as well. And this is why we think, also in this area, what did you write? Treating the right patient. Exactly. Taking the patient not because you think he's been smoking and is short of breath because he probably has emphysema, but actually measuring what sort of inflammation this individual has. And you also find this in chronic obstructive lung disease. And if you would go earlier into your intervention, you will actually find this more clearly. Because once you've reached the age of 72, have 60 pack years on your back, you don't know really where you are. But if you would have measured this when you were 50 or 45 at risk, probably you would have actually learned and seen more in this, and this is why these things go out there. And that is the COPD treatment of the future. It will be involving epithelial biology. How is it injured? What is the alarmins coming out of that? IL-33, TSLP. How does it govern inflammation? Leukocytic inflammation, eosinophilia. It's IL-4, IL-13, it's IL-5. It is happening in chronic airways disease, not in a silo, as a principle, in the same way. Period. Final paragraph. Next to your trained immunity and the fact that you bring this to the table when you actually are at risk for your exposome that you have, there's very good information on the genetic background of this. So if you look at people with COPD around the world, 600,000 people, 20 studies, Northern Hemisphere, Southern Hemisphere, and you look at polygenic risk scores, that is, you have the same proper genome, there's not a gene defect, but you have single nucleotide polymorphisms that are deviant. So there is genetic instability, if you want, SNPs, SNPs. These SNPs you can measure, and now with artificial intelligence, it takes you 6 hours for 1.5 million SNPs in a given genome. You can say that, you can see that. So if you have a risk proposition to make, if you have a lot of SNPs that are related to your diagnosis of COPD, your risk ratio will go up by a factor 5, 6, 7. So there's a genetic makeup that renders you more susceptible to a type of inflammation, to a type of endotype that you will have, but also giving you a risk for the disease itself. So what we reasoned, taking people out of silo, if that's true for people that are grown up, what happens to people who have a bad lung function when they're young? And these are people, these are children, BPD children, children that are born 1,500 grams or less, they survived this, We have the genetic information of 2,000 of these children. What you can see, the same risk score, the same SNPs that confer the risk of COPD confers the risk of having poor lung function at the age of 12 when you're born premature. It's the same genes. Taking it out of a silo. It's a principle that drives progression of chronic lung diseases. So if you know that, and you know where you are, and you understand which immunobiology belongs to that, you have a completely different way of looking at this. So basically, in the last 10 years, when we said early life events, time, and probably some overlap if you look at physiology only, now that we can look outside the box, that we can look at the times of inflammation and the type probably of multimorbidities, we can still have lung function trajectories. Yes, we have exacerbations, we have multimorbidity, but what would drive the decision and targets is biomarkers and it's your genotype. And the future, which drives chronic respiratory diseases, it's a biological reasoning to understand the immunobiology in a given individual earlier than the diagnosis is made today, with a completely different measure. And by understanding this, you will find new biomarkers and you will find new drugs for the niche that is relatively small now to get bigger and bigger. And it's not by chance that these biologics are not made for one disease. They have several indications. Guess what? They have indications because the principle is different. They address a common pathobiology. Therefore, it doesn't matter whether it's the skin or the esophagus or the upper air or the lower airway, because it's the principle that you address. So it's not by chance that these things are working in different areas, because they get you out of the silo. Thank you very much.
Wow. This was very impressive, and it was just a fascinating talk, and I think all the brains here in the room, they start to work and to think about it maybe differently, but I think it's a very crucial information that we have a more distant look at different diseases and common pathways. And especially for the pediatricians here in the room, the multimorbidity plays a major role also in terms of early prevention. But, we decided to discuss maybe at the end of all the talks. So I move on, and it's a pleasure to have another perspective now on things. Please come to the stage, Philippe. Houssiau. We haven't met before, but it's really a pleasure to have you here. Thank you very much. I have to look at my paper because you have done so many things that I can't really recall them all. You are not a physician. No. So that makes it very interesting for all the physicians here in the room. You are a prominent healthcare executive and visionary. That's what I found. And you had many experiences, many positions, board experience, and you are currently serving as an executive chairman of MedNeo. And you may correct me afterwards. You're chairman of Corellus and a director at RAM Infotechnology. Is this correct? Okay. And you are an expert in the advisory group also of Novo Holdings. And I think you are trying to translate all the knowledge we collect and all the healthcare challenges to healthcare solutions. You're trying to bring it. And that's our mission, to improve diagnosis and patient care. And warm welcome. We are very happy to have you here. I pass you the mic.
Thank you very much. I must say I feel, oops, sorry, wrong presentation. Yeah, I have slides actually. I have too many slides, by the way. Yeah.
Oh,
So.
wow.
Oh, there we go. Okay. Well, good afternoon, and it's true I'm a little bit of the odd duck, you know, in the pond right now, and I feel slightly dwarfed by the previous presentation, right, which I think is completely in line with a lot of the work that I'm currently doing as well, you know, with different angles, and you know, as a background, I'm not a doctor, but I am a pharmacy degree and chemical engineering, and specialized in medical biotechnology, and worked in research. You know, worked with Professor Gallo on HIV, made the first recombinant HIV virus, and with Professor Collin on TPA. So until I turned to the dark side, right, and then and started working in consulting and in business. But currently, I work a lot with Mayo Clinic, by the way, with Professor Kallström, Matthew Kallström, who was chair of radiology there, and also heading up Gen AI, and with Jim Rogers and John Halamka, right? And actually, a lot of what I'm going to be talking about also reflects a lot of what you actually explained, Professor Rabe, is the real, you know, change of the, let's say, call it the, what we've been doing now for the last 100 years, right, is really looking at the phenotypic expression of disease, while there is such a wealth of underlying data that is being made available now, and that we are trying to converge, you know, in a more efficient, relevant, and intelligent way to better support, you know, prevention, early identification, whether it's at genomic level or at transcriptomic level, and basically. When I joined, actually, the first EUFOREA Symposium, I gave a short speech at the end where I said, basically, I see 3 rabbits in this room, right? And they're all rabbits in headlights right now, because you see life sciences organizations that are like rabbits in headlights. Why? Because they continue to develop drugs for diseases that actually don't really exist, right? And you mentioned the fact that there is a great need for a new classification of disease. No longer talking about comorbidities, but about multimorbidities. You know, IBD, Crohn, atopic dermatitis, asthma, COPD, they're all related, and they're all phenotypic reflections of an underlying endotype, an underlying pathophysiology that actually is present, that is usually present already at the early days of lifetime. So basically, harnessing those data sets allows us to, one, predict much earlier and actually prevent by properly predicting, right? And then helping us to avoid people moving into the clinical or the acute stages of their lives too early, and therefore increasing the burden on the healthcare cost, but also the life of the individual patients. And I think I explained most of what I actually wanted to say already during the presentation, but I'll quickly flip through a couple of slides, right? Is it this one? Top one? Yeah. Okay, right. So yeah, just to make sure as a disclaimer, this is not an AI-generated presentation, nor am I a digital twin like ABBA-like, you know, starting to perform in front of you, right? But to go back to a little bit of history lane, right? What we're seeing there is this doctor in the mid-1800s still looking at this ailing patient and basically being clueless, because it was just looking at, you know, what we would be looking at that time, the miasmas that were emerging from that patient, and coming up to some kind of, you know, empirical decision based on experience on what it could be, and then basically telling the parents there was nothing he could do, right? In, you know, the world as we know today, a couple of generations later, you know, has been massively evolving, you know, with some disruptions in healthcare, right? We had Jenner, you know, we had, you know, Fleming, we had a lot of technology leaps, better surgery, but essentially we've been focusing very much on over-investing and investing in those areas to intervene when it's actually already too late, right? And the bulk of the investment has been going into, you know, acute settings, right? Another important thing is that, you know, when you look at history, the major driver of health and longevity is still wealth, right? And with that wealth comes massive variation, right? That variation was there in 1937, right? Where depending on where you lived, basically you had access to different kind of healthcare, but also different kind of life circumstances. Funnily enough, and I apologize to my English friends and colleagues, right? That really hasn't changed, because as we all grow older, and our average lifespan now is about 80 to 84, right? Especially for the ladies, you know, our years of healthy living actually end usually around about the time of 65 on average. But still a great deal of varieties exist, right? If you look at the, you know, the more affluent areas in England, right? Well, you see evolution, 21, 23, 70 years, coming about the same. But if you look at the more less affluent areas, right? 56, 53, 55, 51. Massive difference. So we're not just dealing with, you know, generating better outcomes for individuals. We're also dealing with, basically, managing variation. And that also is a very important task of what we need to do. And I'm sure you're all familiar with the Rosa curves, or the Preston curves, as they call it, right? Where basically they determine that the actual basic factor of aging, right, is basically determinant is wealth. And with wealth come a lot of interesting lifestyle diseases. Why? Because we have been genetically programmed to deal with scarcity, not with abundance, right? And that abundance was there when you look at smoking, it was there when you look at sugar, it was there when you look at all sorts of other things, especially around, you know, environmental factors. That has led to this lifestyle epidemic, right? And all the diseases that we are currently facing. The interesting thing about that is that while we, I'll go back. While we all consider these as being, you know, discrete disorders, again, this is just a phenotypic expression from an underlying pathophysiology that we are now only starting to really understand and potentially deal with, right? With that, you see the projected rise in cases of chronic disease. And again, pulmonary conditions are, you know, if you look at population growth, and this is a relatively old slide, it has already changed and actually increased, right, is, you know, 31% versus population growth of 19%. So we are continuing to add to that massive deficit caused by the rise of chronic disease and our inability to deal with it. So what is actually the size of the prize? I'm sure you all know this curve, right? But, you know, in an ideal world, if you look at the green, the green part of the slide, this is what an ideal lifespan would be, right? With the most costly, you know, 2 weeks in your life would be the last ones that you will spend. The reality is that, on average, we all get chronically ill at the age of 65, right? And that 65-year age has not really dramatically changed over the last 2 decades. What has changed is how long we live, you know, with a whole bunch of comorbidities or multimorbidities, as we call it, right? And leading to a set of avoidable acute admissions. But basically, what the size of the prize is from the cost of healthcare is actually that surface under the curve. And if you look at diabetes, you know, T2 diabetes, where about, just take the UK again, about 30% of the population is pre-diabetic. If you know that of that 30%, about 8% will convert to declared T2 every year, and that for every declared T2 conversion, you add about 120,000 euros of lifetime healthcare cost, right? It's not hard to do the equation. It's also not hard to start looking at how can we mobilize the resources, the information we have now, to build some new foundation models that actually allows us to use the tools and the techniques that we have, use the data sets and the tacit data that we currently have, and make them more explicit so that we can actually start really bending that curve. As we all know, right, the electric light wasn't, invented by the continuous improvement of candles. And our healthcare industry typically is a very conservative industry that doesn't really know how to deal properly with the disruptive side of change. Yeah. And that is a big problem that we're facing right now. So we need a kind of new health paradigm. And in order to get to that new health paradigm, we need to align a number of things, right? We need to mobilize patients. We need to empower patients. We need to move from acute-centric to preclinical. We need to move from diagnostics to predictive. And that shift from diagnostics to predictive analytics, with all the data that we can actually gather, we need to start doing that. When we were in the midst of COVID, I was actually in touch with a hematologist in Pretoria. He was actually running the ICU in Pretoria. And the guy managed to avoid a lot of, deaths in his ICU unit. Why? Because he was actually measuring blood, taking blood, pretty much every single day of each of his patients. Why? So that when he saw that actually, the dimers were starting to go up, he would immediately medicate, right? And that was just one example, but they were constantly following up the data sets, right? Why on earth aren't we not, doing a transcriptomics analysis for all newborns, right? That potentially could be at risk for, T2 inflammation, and identify the underlying pathophysiology pathway so that actually we can, first of all, start preventing, putting them on, I don't know, dupilumab, from the age 2, if necessary, but also starting to predict what the likely outcome was if you start to treat that patient with that particular drug, right? Because that's also one of the big problems, right? If you look at a recent study that was published in Nature, right? For every person that the 10 highest grossing drugs help, between 3 and 24 people fail to improve on conditions. That's not because those drugs aren't good, or they don't really work, or they're intervening specifically on that element of the pathway that is affected. It's basically that we are shooting with a big cannon on one particular mosquito, right? And we don't really understand what the underlying pathophysiology is, so we cannot properly medicate, with the right kind of drugs. And that's the case for dermatology, that's the case for gastroenterology, that's the case for, respiratory disease, right? And it's such a small thing to start taking those sputum samples and doing, bulk RNA, single cell, whatever kind of sequencing you want to do, and provide a data set that gives you an idea of, where actually the problem lies in terms of the pathophysiology pathway or the nodal pathway or any kind of pathway that you want to do. That spatial transcriptomics, design is something that is currently under full development right now. But we don't really have the foundation models yet that align life sciences companies, clinical practice, clinical research, and technology to make it happen at full scale and mainstream. One of the culprits in that is, are the healthcare IT systems. And you're going to be surprised by that, right? Because, everybody knows the woes about implementing Epic and the other big IT systems. Well, I think we lost about 20 years by doing that. Because actually what you've done, if we created, just like we have in clinical practice, we have silos right now. And one of the great things with EUFOREA is that for once you bring together upper respiratory tract with lower ones, right? And guess what? There's so much to talk about, and there's so much to align in the way we deal and treat with patients. Well, the same counts from the IT system point of view. We have spent billions and billions of dollars implementing systems of records, mainly in the acute side, right? The problem is that most of those systems were actually closed in nature. That means that you could not easily extract data of that, and those data were not necessarily compatible with the data that were coming out of other systems. On top of that, a lot of those systems were oriented towards revenue cycle models and billing, not really to clinical practice. So the applications that were sitting on top of that, actually the stuff that you guys need to work with, actually were faced with the same flaw. And they were not operating cross settings. So you could not basically use the same kind of records for use in primary care, secondary care, tertiary care, or acute settings. And then on top of that, it was very difficult to extract data sets to provide insights to land at the moments of truth in any kind of clinical workflow, right? That's been one of the big problems right now, because now what we are facing when we start to access those data is that the data sets are not normalized. 80% is still unstructured, are still PDF files or other clinical notes that we still have a hard time structuring in such a way that we can make the data sets explicit and relevant, right? And that is one of the big building, blocks that we need to fix. So what we need to create here is actually data liquidity so that the data can be extracted, normalized, and put in context in the best possible way. So basically this is a plea to start setting up this new foundation model that, exactly to your point, Professor Rabe, basically acknowledges that the underlying pathophysiology is a main underlying cause of multiple phenotypic expressions, right? And this is specifically for immune-mediated inflammatory disease, but it's actually exactly the same for oncology pathways, right? That should be leading to a new classification of disease, right? There is not one single thing as COPD. There is not one single thing as asthma, right? And there is not one single thing as something with comorbidities. No, there's multimorbidity, right? And identifying that at the level of patient one, and that's where also life sciences organizations should be more looking at trial of one than just health population trials, right? It's a very important thing that needs to be addressed in the future. But leading to a convergence of data sets made relevant on a personalized and population basis. Why can't we start, mainstream when we have a patient or when we have a patient to be, right, doing a full transcriptomics analysis and mapping the histopathology, mapping, not just histopathology, mapping the pathophysiology and bringing it in relationship with the histopathology, the serologic information, and the phenotypic information that we dispose of. It is all possible right now, and it can be done. The problem is we need new foundation models that help us bring it mainstream in towards personalized care and preventative care, so that we can go to first time and right time treatment. How many patients do we have with rheumatoid arthritis that have to go to Humira and then another one and then another one and another one until the right drug? It would suffice to really look at what the underlying pathophysiology is to see where specifically you need to medicate and what kind of inhibitor that you need to use, whether it's a JAK, whether it's dupilumab or any kind of other one that you would use. A very important element is to complete spatial transcriptomics, genomics mapping on an industrial scale, but with trusted partners to start developing new therapies and, repurpose existing ones, right? Because there's a lot of bread and butter actually in the repurposing of existing drugs. But we need to have models that allows us to do it and that basically build that interrelationship between the data sets that are available, the normalization of the data sets, the validation, the algorithms, and the life sciences companies. So this requires a new technology-driven alliance between clinical research, drug development, and clinical practice. So we need to find new kind of foundation models that allow us to do that. With Mayo Clinic, we have already done that. One actually with Charité, where Mayo had actually used 20 million slices, completely digitized, and brought that in context with their 10 million patient records, which are normalized and anonymized and hidden in plain sight. I think the results of that initial Charité study has been published on the 9th of January of this year, and there's a lot of further development work underway. The next holy grail is actually the triangulation of data sets between morphology, histopathology, and multiomics, right? Because that is going to give even more accuracy in our prevention, diagnosis, treatment, and life sciences development. So, technology-driven paradigm shift, trying to make those tacit data sets explicit, longitudinal, and liquid. The phenotype-endotype combination, transcriptomics, genomics, methylation, and I think it's not just about the SNPs, it's also about methylation, histone structure, chromatin. There's so many other elements that are determining in nature, right? Triangulation of data sets, using federated normalized databases with AI accelerators. There's been a number of initiatives, Biobank and others, that actually are beginning to generate those data sets that can actually be used for cohort definition and actual analysis. Using typical AI, machine learning, neural networks, and the buildup of digital twins and companions. When we talk about trials for one, why don't the life sciences companies provide a digital companion to each patient? So basically you can capture, harvest the data, and have a bilateral communication and connection with those patients and the provider of the drugs. And then basically what's going to happen when the next generation comes is the move to quantum computing. Right? As Feynman, Richard Feynman said, the only way that we can actually start working with the natural world and understanding the natural world is by using computers that don't work in a deterministic way, but actually that work in a quantum way, right? So welcome to the multiverse, right? With Novo Holdings, we will be launching the first 40-qubit quantum computer in Copenhagen, actually, in 27. And there's already a whole network of associated healthcare organizations that will be doing the work around that. But this is really going to revolutionize the way we basically try to copy and reflect the natural world, because you cannot do that with the current deterministic models in reality. I will stop here because I think I've largely overspent my time, and happy to continue the conversation later on. Thank you very much.
Thank you so much for very inspiring. It's good to be a female, rich and living nowadays. And for the next talk, it will be Professor Peter Hellings. Professor Hellings, you are one of the very important ENT surgeons in Europe or in the world. You were working on different places, both in Belgium and Holland, and you were professor at 2 universities. You are head of our EUFOREA, and you are always calling late at night. Or sending a WhatsApp or texting early Saturday morning. Are you awake? Peter, for you.
You did not finish your lecture, Philippe. Okay. Let's have a look. So welcome. It's a true pleasure and honor to be here with you, and I feel very humbled by having world leaders here at the front row and also in the back of the room here. And I'm actually not an intelligent guy. I'm a very simple guy, but I think the major achievement of EUFOREA has been to bring intelligent people together. Intelligent people with a passion to improve care in the field of chronic respiratory diseases. And this is exactly what I will be sharing with you now during the next 10 to 12 minutes, because I want to hand over the floor to Dr. Castro, or Mr. Castro, from WHO. That is our guest of honor today, and we're very privileged to join forces with the relevant stakeholders in the field in order to guarantee the best possible future of EUFOREA. So first, I'll give you a brief introduction of what EUFOREA was all about in 2015, and then I'll give you a hint about the next decade. Of course, the next decade is always looking in the future with some predictions of what will happen, but I'm happy to share that Dept will see the daylight with some passionate people in this room, and I'm happy to share some of the ambitions that EUFOREA has for the next decade. Exactly 10 years ago, EUFOREA organized a symposium about precision medicine in chronic respiratory diseases. And this was actually a copy-paste of what President Obama launched in the US. There was a precision medicine initiative in the field of oncology, and we thought like, okay, if they focus on oncology in the US, let's focus on chronic respiratory diseases in Europe. So we organized a symposium on precision medicine in allergy and airways disease with the support of the European Commissioner, Vytenis Andriukaitis, who encouraged us to make this foundation, EUFOREA, in Brussels, actually bringing together all the different stakeholders like EACI, the European Respiratory Society, the European Rhinologic Society, patient organizations, Galen, ARIA, and the others, that all joined forces in order to improve care for those suffering from chronic respiratory diseases. So that's how it all started. And the day after that symposium, we were lucky enough to have the Bailly Latour Foundation, which is a Belgian foundation, to support the early years and the first years of EUFOREA. So we started with the design of a name, with the design of a logo, with the composition of a team, and this was how it all started. The vision and the mission of EUFOREA are different from other organizations, because sometimes EUFOREA is considered like a competition, but this shouldn't be the case, because EUFOREA focuses on optimal care in daily practice. It's not about big events, big meetings where the latest science is being thrown in the face of all physicians that cannot implement the latest science the days when they come back in clinical practice. It's all about offering physicians and all the stakeholders in the respiratory field with the tools they need to optimize care. So simple guidelines, simple educational tools, understanding, making the GINA guidelines, EPOS guidelines, and other guidelines understandable for primary care, secondary care, and all the tertiary care providers. So the mission is to bridge the gap between the latest science and the clinical practice. We heard this morning in the debate that it takes around 20 years between a concept that is being defended on stage and the implementation of that context in clinical care. And I think EUFOREA is the organization that can speed up that process. There are 3 pillars of EUFOREA: research, education, and advocacy. And the unique achievements, well, you can find them on the corporate video that has been shown and that will be shown also during the coffee break. But we're proud about the research, education, and advocacy activities that have been developed during the past 10 years. I will not go into detail. You find them on the website. They're open access, so everybody can find them. But what is nice is that we have a growing number of experts from different horizons that all joined forces in order to improve care for those suffering from chronic upper as well as from chronic lower airway inflammation. So the expert panels are in full expansion, and now we are establishing a COPD panel. We are also establishing more a patient expert panel. So there are many dynamics going on that all help us to fulfill the mission of EUFOREA. And during the last summit, every 2 years, there is a summit with the experts and with the corporate partners of EUFOREA. We define the plans and the strategy for the next years. And there we already laid the foundation for what will happen the next 10 years. And this will all be around strengthening what has been done, so keeping on doing what we have been doing in the field of education of physicians and patients, also research, including real-world efficacy data, including also consensus meetings, including the development of a control test, not only for CRS, but also for global airway disease. So all of these activities will be going on. But besides that, we will establish a digital platform that will generate, or that will allow us to do the analysis on what is really needed in order to understand diseases better, in order to bring the answers to what Professor Rabe and Philippe Houssiau have mentioned as the unmet need, the major unmet needs in the field of chronic respiratory diseases, as well as build a digital companion for patients as well as for medical doctors. So a digital companion is highly needed, and here we take the knowledge of our previous attempts to build a digital platform like the allergic rhinitis application, like the My Sinusitis Coach, and like also some other digital platforms that EUFOREA was involved in. We take the knowledge from these platforms and we will bring it together in the concept of Dept. Dept is all about the acceleration of a paradigm shift between EUFOREA and it will be EUFOREA, Dept, and the partners that really believe in the need for a change and a need for a disruptive change that will allow prediction, prevention, big data, and artificially intelligence-driven notifications to patients as well as to physicians, as well as bring innovation and also some disruption in the field of chronic respiratory diseases. We do believe that if EUFOREA and Dept will manage to achieve these goals, that actually the shortcomings of care highlighted by Xander Bertels will be overcome to the benefit of patients, like there will be speeding up of the diagnosis, so no delay of 10 years before a patient with CRS or a patient with asthma is being diagnosed, but based on the screening tools that EUFOREA will develop and the inclusion of these tools and the referral guidance of primary care physicians, we will speed up the diagnosis with the more accurate diagnosis, speeding up referral as well as predictive biomarkers that will be included in the diagnostic workout of patients. Also increasing and optimizing treatment outcomes. You can call it value-based healthcare, outcome-based healthcare, more precision medicine, however you would like to call it, and what is actually in fashion nowadays. But we don't care so much. We focus on what is needed, and also for healthcare system, a smoother transition between primary, secondary to tertiary care will hopefully be included and part of the achievements of Dept, and more interdisciplinary collaboration. And also cost savings for the society, because we do believe that when you treat the right patient with the right treatment at the right moment in the disease journey, you will achieve better outcomes of care. And last but not least, innovation will be embraced, and we do believe this will also facilitate and enhance innovation and facilitate the recruitment of patients in trials when they remain uncontrolled for longer periods. So Dept is all about uniting all the stakeholders in the field of chronic respiratory diseases, prevent chronic respiratory diseases not only at primary level but also secondary and tertiary prevention, recognize chronic respiratory diseases early and better, and also understand better, and also empowering the patients, because we may develop all these educational materials for patients at the EUFOREA website and disseminate through our own tools. But if we reach out to patients directly through a digital companion, I think we will empower patients even more and have better outreach of EUFOREA developed materials. 2 years ago, we already published a kind of consensus meeting, an international consensus meeting on all the criteria for e-health tools in the field of respiratory diseases. And this is based on our experiences with the allergic rhinitis app, with My Sinusitis Coach, with all the other respiratory apps that are available. We take the shortcomings of these learnings and we will implement them in a new digital companion that will hopefully help patients and also bring values for patients, for the society, for the different stakeholders that are involved in respiratory care, including our corporate partners at EUFOREA, as well as health policymakers. So I hope you will join us in our future ambitions and also be very excited, as the patients are at the end of any kind of debate. This was taken at the Global Awareness Day one year ago, where patients are always very excited when they can share their suggestions for better care. And this is exactly what we take into account. So during our Global Awareness Day that was held this morning, patients expressed not only the shortcomings of care, and this is now the example of chronic rhinosinusitis with nasal polyp, but the same applies for COPD, for asthma, for chronic rhinitis. Patients also suggest us to improve care by better coordination of care, multidisciplinarity of the approach, harmonization of care delivery across countries and across regions, education of physicians, implementing precision medicine, and all the other aspects that patients consider to be crucial in order to have a better quality of life and cost saving for the society. You may know that EUFOREA renders us all in a euphoric state, and that's why I dare to call Vibeke and Glenis and Suzanne even during the weekend, even during holidays, because that's the time where we can spend some time on EUFOREA. But we enjoy our time, and I hope some of you will join us during the philanthropic dinner that we will have this evening in Brussels. So please, if you want to know more about EUFOREA, join us at the EUFOREA website or register for the newsletter. better. And I thank you for your attention and more specifically for your support and for your presence here today. So thank you very much.
Yeah, it's now my pleasure to introduce the keynote speaker of this afternoon, José Luis Castro. As you have heard, he's from WHO, Director General Special Envoy for Chronic Respiratory Diseases, and as founder, former president, and former CEO of Vital Strategies, you have a profound and long-standing commitment to improve global health with impact on tobacco control, which is right to the pediatrician's heart, I can tell you, especially if you come from Berlin, where every second person smokes, as well as mitigation of tuberculosis, still a hot topic, especially with migration, etc., and air pollution globally. So welcome. We are very curious to hear your talk on global challenges and action plans on chronic respiratory diseases. Thank you.
Thank you very much. May I close? I will close this. I need to put. I didn't bring slides, and it's very hard to follow all these really eloquent and brilliant speakers. But I will. I would like to say thank you very much for inviting me to be part of this symposium, and also to tell you a little bit about the work that the World Health Organization is doing to elevate chronic respiratory diseases in the global agenda. But before I do that, I want to say congratulations to Professor Hellings and also to EUFOREA on this important milestone, this 10-year anniversary. You know, as a founder of an organization from day zero to the 10 years, I know exactly how it feels, you know, for the organization to reach a milestone. At that time, the chairman of my board, Jimmy DeViel-Castel, told me, you know, the first 10 years are the hardest ones. And I believe so. I think after 10 years, the organization not only walks, it runs, and I think it gathers more attention and it has more potential. And Vital Strategies during the first 10 years, actually, when I started, it was 3 friends of mine. It was also three men who started it. And then as the organization grew, 2/3 of the organization, 700 staff, were women. So we did have a big transition. In those initial years, the organization was known as the World Lung Foundation. It started focus on essentially tuberculosis and tobacco control. But as we work with the countries, we realized that to address many of these issues effectively, you had to address a whole system, a system of collecting data, a system of training staff properly, a system of communicating effectively. And it was with that vision that we expanded the name to be Vital Strategies, and then work on road safety, work on civil registration and vital statistics, food policy, overdose prevention. So the whole range of activities beyond the initial lung. But we always kept a big focus also on the lung, because I think without the lungs there cannot be other health. So I'll tell you a little bit about why this role of a special envoy for chronic respiratory diseases at the WHO. And this reflects a commitment of the organization, especially of the Director General, Dr. Tedros, to prioritize chronic respiratory diseases. You know, as you know, diseases that affect over 600 million people in the world, that kill 4 million people every year. And yet, in Geneva, the World Health Organization, there was only 1 staff to address chronic respiratory diseases. I think that we need more than one staff. We need a whole building in the World Health Organization. AIDS and HIV/AIDS has a whole building to address this issue. With this position, the WHO aims to increase, to bring chronic respiratory diseases into the global political agenda. I think that it is important that this becomes a priority for decision makers in countries so that more funding for research is made available. I was listening to Professor Rabe, who said there was a valley of death. I think it's what you meant. There was a period there was no investment and no research, and I think that it's not because chronic respiratory diseases was not happening and people were not dying. It's just the politicians had other priorities, and I think the governments had other pressing issues. And I think through this work, the WHO hopes to will work very hard to put it on the global political agenda so that resources are made available to facilitate research, to invest in the primary healthcare systems of the country so that early diagnosis happens, and also the proper access to medicines. But I think that will require a shift on the conversation. When we speak in Geneva in WHO, it's a scientific language, and the language that we as a scientific community understand, and it's based on the science and the research. When it goes to New York or when it goes to the Ministry of Finance, it's a different conversation. And it's a translation of what this means for the economy of the country, what this means to economic development. So it is important for us to think on how we simplify this narrative so that chronic respiratory diseases is not just a medical issue, but that it becomes a development issue. It becomes a present economic issue for countries. And part of the work that I have been doing in this regard is to broaden this conversation to bring in other parts of the government to look at the disease, to take notice of what is the cost to the countries, as Xander pointed in his first slide, the cost to the economy of the countries if no investments are made to address or prevent these diseases. We have an opportunity this year with the United Nations holding the 4th high-level meeting on non-communicable diseases. And we're working very hard to make sure that chronic respiratory diseases are included in the political declaration that the heads of states will issue in New York. It is a very hard lift, I have to tell you, because we have other colleagues that we'll know from cardiovascular diseases, from diabetes, from mental health, from cancer, that are also doing the same thing. And they actually have larger battalions of people, I think, already engaged in this effort, and also the precedents that people understand what those diseases are. We have a challenge with explaining chronic respiratory diseases to the public at large. Just earlier this month, we began a new initiative, which is to work in training the leading health journalists of the world on chronic respiratory diseases. The first of these workshops with the support of Sanofi was held in Mexico City, where we have a cohort of 15 initial journalists from news organizations like The Guardian, The Economist, Foreign Policy, a different type of media organization to broaden this the audience and to bring chronic respiratory diseases to a larger platform. When I took this job in September, there was a mention of chronic respiratory diseases in the New York Times, not because of my appointment, but because of what? The death of the singer Sinead O'Connor. The cause of death was bronchial asthma and chronic obstructive pulmonary disease. Even the New York Times struggled to explain, I think, in the obituary, or in the article reporting the cause of death, what this disease means. 4 million people are dying. That's like having several airplane crashes happening, and it doesn't make the news. We have to make noise so that it makes the news. That type of news, because that is what policymakers, what the people who have who control the decisions about resources read and are influenced by. Through this effort, we hope to train about 75 of these leading journalists from all over the world who will amplify this message, who will explain to larger audiences what chronic respiratory diseases are and what it means to them, to communities, to societies. But bringing the attention to the media is not, that is just one aspect. And it's an important aspect. When I started my career in New York City in the 1990s, it was in tuberculosis control, and at that time, people were dying of tuberculosis in New York City, first by the hundreds, then by the thousands, and this was not even mentioned in the news. Then one day, a prison guard in the city of Syracuse, which is far away from New York City, had contracted tuberculosis from a prisoner from, in New York, they have a system where they rotate the prisoners throughout the state of New York. A New York City prisoner had been who had tuberculosis, drug-resistant tuberculosis, was transferred to Syracuse and infected this guard, and this guard died along with the prisoner. The following day, the New York Post, the New York tabloid, a big front page headlines that say, "Killer TB." And those two words alone will change the course of the tuberculosis discussion for the next 20 years, not only in New York City, but globally. Suddenly, people learn about tuberculosis. Then resources were mobilized. $1 billion were found from where there was no $1 billion to invest in both in the government and in the private sector to retrofit facilities to address these issues. Two words generated suddenly so much attention. And I think that is the power of the press and the power of the media to communicate to the public the importance of diseases. And we have, with chronic respiratory diseases, a bigger challenge because it's not infectious. And it isn't something that a person can get from having dinner with someone who has asthma or someone who has COPD. So the fear factor that infectious diseases have, whether it's Ebola or COVID, it's not there. So the argument, the engagement has to be more creative. The other group of people that we're trying to engage are parliamentarians, and these are members of the health committees and parliaments from around the world, people who control the resources or who influence the decisions about resources in different countries. It is important to have political champions in every country that speak for chronic respiratory diseases, who defend the budgets that are allocated for chronic respiratory diseases, and who put this issue on the legislative agenda. And to that extent, we are working to engage parliamentarians from different countries to develop a caucus of parliamentarians to address this issue. And I think that your research, the work that you are doing, and knowing these political champions will be important to help secure resources in the national budgets and compete for those resources, because governments are under pressure to do that. We do have an argument that we make, and the WHO has made this argument, that governments can raise money to address chronic respiratory diseases by taxing those products like tobacco that are harmful and contribute to chronic respiratory diseases. And there are some countries that have already enacted legislation and taxation of tobacco products and other harmful products. The third group that is also important and has been mentioned here by the previous speakers is the importance of the patients and giving voice to the patients so the public understands who these people with asthma and COPD are, what they look like, and to understand that they're not very different than the person sitting next to you or the person that you see every day in your bus or in your restaurant or whatever it happens to be, that these are normal people that are affected by the disease. So changing the way that we present chronic respiratory diseases to the public is an important part of this work and part of what we have engaged experts to help us in a way to work with some of the top creative agencies in the world to help us change the face of chronic respiratory diseases so that we reach a larger audience. You know, last week, earlier this month when I was in Mexico, I met this young man named Jaime Barba. He is a COPD patient. And not only him, but his sister is also affected by COPD and is oxygen dependent. He grew up in a family where everybody smoked, and him and his sister also eventually became smokers until they developed the disease. You know, he's become an activist to try to dissuade young people from smoking and also to bring attention to the issue of COPD. I think that we have, in that sense, the importance of the advocacy of patients and how powerful that is to illustrate what living with this disease means, and the limitations and the challenges that it brings to families and to communities and also to countries having hundreds of millions of people affected by this disease. In the past few months, we have been working with the WHO, members of a number of organizations that are here also present, in trying to define the ask that the global chronic respiratory disease community has for the political leaders in New York. And that, I will spend a few minutes explaining where we are in this effort, because it's important, and it will be important also to have your support going forward on how we amplify this message and also engage with the political leaders in your respective countries. An organization called the Global Alliance for Respiratory Diseases, or GARD. The members of this organization have outlined 5 important areas, and I'll share them with you. The first is that we are asking countries to take action on chronic respiratory diseases. I mean, there have been 3 previous meetings on non-communicable diseases. Not one of them, the political declaration, mentioned chronic respiratory diseases. So it is very important that we lobby hard and that we work very hard to make sure that chronic respiratory diseases is recognized in this year's political declaration. That is important because that is a statement of commitment by the world leaders on this issue, and it will help in the national advocacy to ensure that programs are developed and that budgets are allocated to address this issue. Second, we're calling for multi-sectoral partnerships, and this includes air pollution, housing, tobacco, workforce exposures. Not only problems that the Ministry of Health can fix, these are problems that will require different aspects of society and different institutions to get involved. Third, we must strengthen primary healthcare in countries. We can have medicines and we can have treatments, but if there isn't a strong system in the countries to deliver that, then it doesn't reach the patients. This don't reach the patients. To ensure that there is significant investment in primary care. The fourth is access to essential medicines is non-negotiable, and there are a number of organizations also that are putting this as their one request, and we're supporting that along with all the other items that I just outlined, and most importantly, the investment in the primary healthcare services. Fifth is that we must invest in data and research, and I think the governments need to make a commitment to funding research to develop new diagnostics and treatments for chronic respiratory diseases. And that will require a lot of noise, a lot of advocacy, and also the voice of and the active involvement of patients in lobbying. We don't see, we see this as essentials that may not necessarily be in the political declaration, outlined as I described, but that they will serve for us as points that we will use to implement after the meeting in New York. The meeting in New York, as you know, is just one-day meeting, and the heads of states are there and make a statement, and everybody goes home and they go on to the next issue. But that's actually like a graduation from the university. That's when the work really begins. That's when the work in every country. It's important to focus on the implementation, on holding the countries accountable for the commitments that they make in New York to show progress, and also, most importantly, that ensure that the diagnostics and the medicines are reaching the patients. So these are 5 areas of our roadmap, and each of you will have an essential part in turning them into reality. I think that we have to, as a community, make sure that the world understands that strong lungs mean also strong economies, and the only way to reach that is to invest in prevention of chronic respiratory diseases. So, what comes next depends on how well we also organize and how we advocate and how we support the countries to follow up on that political declaration. And that won't happen unless we link arms with different organizations like the ones here today, but also reaching beyond, as I mentioned, reaching to the finance sector, reaching to the housing sector and education. So I close with this, that every breath matters, every delay costs lives. Every step that we take together towards awareness, investment, and action will help someone breathe easier tomorrow. So let's not wait for that perfect moment. Let's make this moment matter. So thank you very much.
I'd like to thank all the speakers. Thank you very much, especially those who had a long way. But I think this has made a difference and a strong impact. And so we now have to think about the future and how we are going on to strengthen the care of chronic respiratory diseases, which we will. So I'm looking forward to a wonderful evening, and see you soon. Thank you.